Can you see my slides?
Yes, hope you can see it.
Okay. So like I said, I've been asked to speak about the pathways, to break it down, yeah. And I've also been asked to talk about the global importance of having it in the curriculum, as well as share a little bit of my experience. And like I said in my introduction just now, uh, can be stormy and can be smooth for some. So mine was pretty stormy, because of the choices, difficulties in getting selected into anesthesiology, because we did not have many posts at that time, or post or place in the universities. And there were less number of universities when I was trying to apply. So there were a lot of reasons why I could not. And that is why I attempted to do anesthesia, because I really liked it. And I actually got into it in, uh, I must tell you how I got into it. I was a medical officer in Hospital Permai, which is a psychiatric hospital in Johor. I was posted there, and I took leave to go back home for a week. When I came back, the boss told me, Thiru, you have to go to hospital Johor Bahru, because we want to have you be trained to give anesthesia for ECT, electroconvulsive therapy. Yeah. So I went. I had no choice. I wasn't happy at all, but I went. I had no choice. The boss said go. But when I went there, and the boss there told me, you can't just come and do anesthesia just for ECT. You need to do everything and be able to handle the whole problems and so on, because anytime you anesthetize a patient, things can go wrong. So I had no choice, and he made me tag every day for the first week. So I thought it was just going to be, just focused on ECT, but no, it wasn't. And I'm glad he did that and he made me do it, because after a few days of tagging, I realized this is it. This is what I want to do, because the again, it depends on individuals. And you might be one of those who cannot or do not want the ups and downs in your heart rate and so on. But I love that challenge. I love the not knowing what kind of patient I'm going to get next. All that, in that 1 week of tagging, I decided, okay, this is it. I want to do more. I want more. Of course, but I was posted to Hospital Prima and I had no choice. I did the training for almost 6 weeks. I had to go on call and do calls. I tag called, and then I did calls on my own solo. And I knew by then, by the end, I knew this is what I wanted. So, but getting into anesthesia was the challenge, because I was in psychiatry, in a district kind of hospital. When I got transferred to Ipoh, they put me in Hospital Bahagia because I'm from psychiatry. So I had to really work myself out of there, get into, anesthesia much later. After a few years, I applied for masters again and again. And what happened was I decided, okay, I'm going to do this on my own. So I went and did it in Singapore. So because I kept not getting a place in masters, even after joining anesthesia in KL for a few years. So that's how my journey started. And once I got my master's part one in Singapore, I managed to get a place in the masters in Malaysia in USM. And my husband was transferred to Kota Baru as the head of ENT there. And then so I said, okay, I got this, I've got part one of this, let me do both. So I ended up getting masters in Malaysia as well as in Singapore, which was a good experience. And that's how I became an anesthesiologist. So I just made it all very simple, but it can be quite complicated. But some people, when they apply it the first time, they get a place, and the journey starts. So, like I said, all of us have a path we are going to follow. Yeah. So I'm just going to, I just shared a little bit of my experience, but I am now going to take you to a little bit of history because there must be meaning to what, anesthesia is all about and where we came from. So I've just put up this about this lady called Fanny Burney. Yeah. Fanny Burney is a story that when I read, I felt it really affected me because this was in the in early 1800s. She was only 20 plus years old. They diagnosed her to have breast abscess. And finally, she gave in, and because of the pain, she decided she will get a mastectomy done. And these are the words that she wrote down. She's a novelist by profession, I think, at that time. When the dreadful steel was plunged into the breast, I needed no injunctions not to restrain my cries. I began a scream that lasted unintermittently during the whole time of incision. So excruciating was the agony. I felt the knife raking against the breastbone, scraping it. She apparently fainted a few times, came around, fainted. The only thing they gave her was a drink. At some point people were given alcohol and so on to sort of mute the pain. But this, um, went on for quite some time, up to the middle of the 19th century when there was this landmark period when ether was recognized and used. The sad thing about this this anesthesia is that there are many told and untold stories in the history. People find, like Humphrey Davy, I've put up his picture there. It was just a 20 plus year old chap. He found nitrous oxide, which is a laughing gas. He put in the proposal to the surgeons, but the surgeon said, no, patient should have pain. Uh, then they will heal, the body will react, and so on. But it was much, much later in 1800s when nitrous oxide was recognized. So that's what I mean when I say that people find something, but you don't actually get to really use it clinically until maybe someone more prominent works on it. So this picture of ether monument, but it's called either monument because they've not put any names there because people are fighting to say I discovered ether. But when you really go back and look at history, everybody assumes it started in the Western world, but in Japan, people were using it in the 1800s, and even the Sumerians, Babylonians, the Indians, Chinese have been using it much before than that. So, but over time there were changes. But if you can see, the last one here is Dr. John Snow. I find that most of them were dentists, who discovered ether, who dealt with nitrous oxide and so on. Here, Dr. John Snow is an obstetrician. He gave Queen Victoria, chloroform. And because she was good after that, it became something that people accepted. Yeah. Before that, they say birthing, you should feel pain. A mother should have pain. But after they used it on her, it became more accepted. And this is the landmark painting. This is the first time ether was used for excision of a neck lump. And you can see the guy there holding the canister. That was ether that he gave. And that's when it all began. Yeah, that was the modern anesthesia. This is what super modern, I suppose. This is what you see when you go into theater. Though I do know now that a lot of you have had anesthesia posting. This looks daunting, but once you get understand where the machines are, what each component is all about, it becomes really, really simple. Yeah, but it does, I agree, look very, very complicated. So what is anesthesiology? GABA are one of prominent anesthesiologists who introduced patient safety. We are leaders in patient safety worldwide, as well as simulated training for crisis resource management. And GABA says that anesthesiology is a branch of medicine that shares many domains uh, and domain characteristics with aviation. These include dynamism, complexity, high information load. Yes, you have to know a lot of basics, variable kind of workload. For us, they say moments of terror and hours of boredom. That's what many people think. We sit there, we don't do anything. That's why we say variable workload. And there's a lot of risk involved. Patient safety is a huge thing. So, who are anesthetists? Well, I looked around and these are the things that I saw. And these are things that my students actually mention when they write reflective reports. They said, I thought anesthesiologists just sat there, looked at their phone and stuff. Nap time specialists, really? ABC of anesthesia is airway, breakfast, and coffee. Educated drug dealers, we are called. And there are so many other names, that we just put patients to sleep and go to sleep as well. But that's not how it works, yeah? So this is just a news report by an anesthesiologist who says that if the surgeons are the blood, we are the brains. We have to fight back, right? And say we don't really just sleep. So they also say I'm an anesthesiologist because surgeons need heroes too, because we are there for the surgeons. Without us, 90% of surgery cannot be conducted, and patients, we are the unsung heroes, basically. Um, we are there to support the patient throughout as well as the surgeons, but we do not get recognition at the end of the day. And you see the other picture there where the anesthetist is holding the gun to the surgeon and saying faster. Well, we do things like that, but not with the gun, of course. Yeah. So anyway, anesthesiology is a very specialized field of medicine, and I'm quite happy to see a fair number of you signed up to come and see what this is about, and if you have a future in this. It's a very safety orientated specialty, and we are leadership in patient safety. We use a lot of simulation to ensure that outcomes are safe. Like I said, very akin to the aviation industry, where they train on simulators before they go in to manage the aeroplanes and so on. And a lot of tips about patient safety and so on has been embraced from the aviation and military industry. Yeah? We are certainly not this. Yeah. What we do is that we provide anesthetics for surgical cases, medical cases as well. We are involved with the medical team, radiology, because sometimes we do procedures under uh, in the radiology department that would need anesthesia, like clipping of aneurysm, is also done using interventional radiology. And here we have to anesthetize the patient in the radiology room and keep the patient from moving at all. So we paralyze and ventilate them there. And psychiatric procedures, like ECT. We also manage pain. Management of pain includes acute chronic pain, cancer pain, labor pain. All forms of pain are dealt with by us as well. And we assist resuscitation of acutely unwell patients in the general ward. If there's a code blue in the hospital, any part of the hospital except the A&E, we get called to come and help resuscitate and maybe take the patient to intensive care. So if you've been going to the wards, you would realize that, these things do happen. And lastly, we lead in intensive care units as well. So high dependency leads and intensive care are generally held by anesthesiologists who have subspecialized in intensive care. So just becoming an anesthetist is now has become just general anesthesiology. A lot of us have subspecialized to do something more. Like I've subspecialized to do neuroanesthesiology. Some people subspecialize to do pain, for instance, or intensive care. So there's more subspecialties involved in this field. So we are supposed to be experts in physiology, pharmacology, and a bit of physics. Not that I like physics, but I had no choice. I like to be an anesthetist, but I had to jolly well learn a little bit of physics because I need to understand gas flows, the equipments and so on. So we need to know things from cellular respiration, how a drug works, internal work, up to the internal workings of a defibrillator, because we are involved in all these. Yeah. So these are just pictures of spinal anesthesia, different types of anesthesia. By now, if you are in final year and you've been exposed, if you just graduated, you would have come across all these. Nerve blocks have become really um, advanced these days. When I started out, I just used initially just needles and the patient's feedback. Then I went on to nerve stimulators. Then I went on to using ultrasound, like this lady is using. So there are many ways. In many ways, we've actually become very, very advanced. And we've got feelers in all the disciplines. Yeah. The other thing is monitored anesthetic care is also under us, where we give the drugs and we monitor the patients. So certain group of patients who need a little bit more than just sedation would be under our care. And we put them off to sleep and we monitor them. And if complications happen or surgeon needs to go more advanced and do a bit more, we end up converting them to general anesthesia. So that is another area. So just a bit of confusion I'd like to clear, because sometimes people talk analgesia, anesthesia, interchangeably. Analgesia is just pain release. Anesthesia is more global. You have muscle relaxation, a state of unawareness, and as well as analgesia. So analgesia is a component of anesthesia. And I put both spelling anesthesia there because the people from USA prefer ANES and ANAES is more for UK based. Yeah. We are basically multitaskers. So if you like multitasking and your personality is such that you multitask, you probably will fit in well in anesthesia. We have to be doing many things at the same time. So a lot of us have to be able to do multitasking. So in OT, what do? We provide continual assessment of the patient, ensuring cardiorespiratory stability. That is the main component that can mess up the whole thing for the patient and the surgeon. We monitor and control patient's vitals. We decide how invasive we need to be for the patient based on the preoperative assessment and the needs. We monitor the heart rate, the rhythm, the breathing, blood pressure, body temperature, even in long cases, because body temperature can mess it up for us when we're trying to reverse patients. Of course, fluid and electrolyte balance is very important, and that's our forte as well. So the core principles when you really think about anesthesia is preparation, preparation, preparation. I can go on saying preparation, and then comes that planning. Yeah, must have a plan A, plan B, plan C. If this doesn't work well, what do? I go to plan B. If so, we try to foresee how a situation or scenario can pan out, and we plan. So that's where the plan A, plan B, plan C comes. So we are already anticipating difficulties and we set in place a solution even before we start. And then comes situational awareness. Situational awareness is being aware of your environment and your people around you and whatever you have available. So suddenly something happens behind you, you need to be aware that, okay, there is a change in SpO2 level, what could have gone wrong, and so on. So situational awareness is a topic by itself for us, and it is part and parcel of the crisis resource training that we do for our anesthesia trainees. And finally, teamwork and communication, I cannot emphasize more. But this is for every discipline. Teamwork and communication, how we communicate with our peers, our surgeons, our nurses, that affects outcome. So these are the main principles that we have to have and adhere to. So I actually asked the last question because I wanted to be able to tell you that, hey, we do this. That's why, and that's what's going to get you to what you want to be when you're a houseman. See, when you start housemanship, you are just out of med school and you are just learning. You are in the lowest rung of the ladder. And you need to be equipped with certain important things that will support your training when you start housemanship. So in IMU, since I belong here, my plan is that my students, when they start anesthesia, they must, not anesthesia, when they start housemanship, they should be equipped with at least some of these things so that they are confident when they are going to interpret an ABG, for instance, when they're choosing an oxygen therapy device, for instance. You've got a simple face mask, high flow mask, you've got all sorts of devices, but you should be able to match your oxygen therapy device to the patient's clinical state. So these are our topics, or rather, these are our areas of expertise. We start out with basic sciences. We do pharmacology, of course. You need to do pharmacology for any posting, any discipline. But I guess ours is a bit more extensive in terms of, things like inotropes and so on. And patient safety is core to our practice because we are so invasive in the sense that you take over a person's breathing and you put them under. You need to make sure that they come back the way they went down, right? So patient safety, machine checks, and the procedures that we do. So the clinical management of acute emergency, under that is where I've put all the ABG interpretation, oxygen therapy, fleet management, therapeutics, or rather therapeutic reasoning, airway management, how you manage a patient who has stopped breathing, for instance. What do you do first? And even CPR, because that is part and parcel of my, personally, it's part and parcel of my curriculum. I actually do that for my students. They hate me for it when they are in the posting, but many have come back and thanked me because they feel confident when they are housemen and there's a patient who's crashing. Yeah, the invasive procedures that we deal with are like IV lines are very common, but CV lines, central venous lines, arterial lines, how to do ABG, the processes involved. So these are the important things that you need to be equipped with when you start housemanship. That gives you that confidence when you have a patient because you are the first responders. You are the one who's going to respond first. So my goal is to get you set for housemanship, but after that, whether you want to pursue anesthesia or not is basically up to you. Now, I was also asked to touch on the pathway if you are interested. There's been, if you've been reading the papers and so on, you might have come across some issues with, there's some noises going on, people who are in the parallel pathway not being gazetted or not being given NSR and so on. So what I do know, anesthesia is still fairly all right. So that's why I'm sharing this with you. When you become a houseman and you, or now onwards, if you decide that you want to do anesthesia, you can either take the main pathway or the parallel pathway. The parallel pathway is based on the Malaysian Society of Anaesthesiologists and their MOU with the Irish anesthesiology team. So you get an Irish degree at the end of it. So you can become an anesthesiologist following either one of these pathways. And once you become an anesthesiologist, you will probably be able to decide what you want to subspecialize in. Yeah. So this is just like a sketch of the details of pathway. You got to become a hospital officer, and when you become a medical officer is when you can start this going. But you can prepare for this when you're a house officer. If you take the main pathway under the Malaysian university, which is the university pathway, you need to complete the MEDEX exam. All disciplines go through the same, orthopedics, surgery. Everybody has to go through the MEDEX, and you can do that a year after completing NS. If you're in anesthesia department, and because it is one of the criteria for selection, you need to have had some exposure with under anesthesia. And then, of course, different universities may have some different criteria for taking you in. Of course, you must have qualification for APC. Yeah? And degree that's awarded is Masters in Medicine Anesthesia. Like mine is from USM. One of my masters is from, so I have Masters in Medicine Anesthesia from USM. Okay, so that way UKM, UM, but it'll be MEDNS. Yeah. If you take the parallel pathway, applicants must sit for the MCAI, MCQ exam. Then on passing that, you may register into the parallel pathway with the College of Anesthesiologists. And then you get first the certificate of completion of training, and then it's followed suit by the Fellowship of College of Anesthesiologists of Ireland. This is also taken from the Malaysian guidelines, after I did some research. So you can see there's a breakdown, selection criteria for Masters in Medicine, Anesthesiology. This is for the hospital pathway. If you can see, there are designated hospitals where they do the screening test. If you are successful, you get to apply to BPL. BPL will be Bahagian Pengurusan Latihan. Once you get shortlisted, and to shortlist, you must be confirmed in service. And your KPI in the last 3 years should be at more than 85%. Excuse me, no disciplinary action. And then you become shortlisted. Once you are liar or eligible, then the HOD will submit a report to the training secretariat, and then you go for your exams. Excuse me. So what about parallel pathway? Like I said, you will end up with, it's a 2-tiered, and it is overseen by the Ministry of Health and College of Anesthesiologists. So in summary, well, it's challenging being an anesthetist. As like I said, hours of boredom, you've seen them sitting, right? We are not just sitting, we actually our ears are peeled to the monitors. So if there's a DSAT, I will pick it up. And the machines are pretty safe. They will call out to us as well. It's really gratifying when I get to put a patient under, make sure he's pain-free, and they come back the way they went under, and they are comfortable and they survive. Let's say very sick ASA 5 or 4 patients survives. After I send them to ICU and they make it out, it is really gratifying. Yeah. Well, I'm repeating, multitasking, prepare, plan, always plan for the worst. That's my personal thing. And I think that most anesthesiologists work along the same line. Is the way we are trained. We always plan for the worst. So if I have a sick patient coming, I'm already planning different pathways that he will end up with. And I plan a solution. If this happens to him, this is what I'm going to do. If that happens, this is how I'm going to handle the situation. So I've already set in place worst possible case scenarios that could happen. And I'm ready when it happens. So this is what I asked you. I wanted to work it backwards. Once you graduated and started housemanship, what do you want to be able to do and do confidently? this is where the role of anesthesiology in medical education globally comes in. I feel that we do contribute quite a bit, but unfortunately, we only have 2 weeks of posting because medicine and surgery and ops and gynae take most of the what do you call, the chunk of the time for training. And but we've been able to contribute, and coming to us in final year, I feel is quite good. And IMU has actually we've now sort of changed our curriculum, and I've been given an opportunity to start in semester 6, year 3, when they just come to clinical school. So I've introduced, so it's all introduction of airways, the oxygen therapy, pain management. It's all introductory, and they'll come back to me in Sem 9. So I have a better way to organize what I would want them to be at the end of final year. Simulation is a lot. You do use a lot of simulated OT first before they enter the actual OT. So the final words to you is that there'll be lots of crossroads for you, and you need to choose wisely. You need to have job satisfaction at the end of the day. I don't think I would have been happy if I'd done psychiatry. I'd been there for more than a year plus, and I wasn't just feeling it, But when I was forced into anesthesia to do ECT, I just fell in love. So that was my journey, and I hope that I have. Well, this is the last bit. If it's money, so be it. Yeah. Who doesn't want money? Yeah. So there must be job satisfaction, and you must be financially stable as well. Yeah. You want to be able to wake up and say, oh, I'm going to go to work. I'm happy to go to work. So that's it for my presentation. I hope that I'm happy to take any questions if there are any.
Thank you so much for Prof. Thiru for the wonderful and interesting and amazing presentation from Prof. Thiru. I believe every single one of us
I had
learned a
turned
lot
off
from
my
this
camera.
I believe every single one of us learned a lot from the sharing session just now. So now we'll be moving on to the Q&A session. Anyone that has a question to ask can type in the chat box. And we have also collected some questions from our audience through our registration form. So let us have a look at those questions. So next slide, can look at the first question. Okay, so the first question will be what the key skills and personal traits are that are essential for someone considering a career in anesthesiology?
Okay, so I think I did mention a little as I was talking. You should be, tolerant. You must have tolerance and patience, because sometimes we get into a lot of situations where we need to be really patient, especially when it comes to caring of the unconscious patients, or trying to get consent, or explaining a very ill patient the risk of death on table and all that. So you might get a lot of anxiety and so on from the relatives, a lot of questions, distrust and so on. So need a lot of tolerance and patience. You need to be able to multitask and hold it in. Yeah. Sometimes I do get upset when relatives say some things when I'm trying to explain a sick patient, but I try and put myself in their shoes. They are desperate. So being able to do that is really, really important. Being able to empathize is very important as well. So I think that, and the fact that you don't mind being the unsung hero that I talked about, you might not get recognition. You might have put in a line. This patient would have died if you had not done all the things that you did intraoperatively to keep them stable while the surgeons did what they do best, maybe stop a bleeder or whatever. But at the end of the day, the surgeon gets the trophy. They say, "Oh, doctor, you're so good. You helped me, and all that." But they don't know that we actually made them that stable intra-op that the surgeons could do a good job. So if you're okay with that, because for me, it's a different kind of satisfaction. So I'm really happy doing what I do. I'm not really particular that people don't know, though people are more aware about anesthetists these days, but it is not that much better. So if you're quite okay with that, then yes, it is a training to go for.
Thank you, Prof. Sounds like anesthesiologist unsung hero for the operation.
We've been known as the unsung heroes for years. So you must go in with your eyes open. I'm not going to get major credit here, but this is what I want
Right.
to do. Yeah.
Okay. Thank you for the question for the answer. So next we'll move on to the second questions. Are there specific fellowship opportunities that Prof would recommend us to take for someone who interested in specializing within anesthesiology?
Subspecialization. Oh, well, I was supposed to do pain. So here comes the hurdles that I talked about. I wanted to do pain initially. So I went for workshop and so on. And then, there's a hierarchy in the system. They said, oh, somebody else who's senior to you has to go first for subspecialization and stuff. And so I lost my chance there. And so I could not wait. So I said, okay, what's the next best thing? Uh, I wanted to do clinical work as well, meaning in theater. So I decided on neuro. So I went and subspecialized in Singapore because one of my masters is from Singapore. It was easy to get a place as a registrar there. So I worked there for a year and I subspecialized in Tam Tok Seng, which is a neuro center. So pain is a good choice because you can, there are a lot of sub to pain as well, but you should also be interested in doing those procedures. In pain, we do a lot of blocks and so on. So if you love doing those kind of things, it'd be an option. We also have obstetric, we have intensive care. So it's up to you at the end of the day. When students ask me, I tell them, some are interested in anesthesia, I tell them, go do your housemanship first. As you do housemanship, you realize where what your mind, what you personally want to do. You get interested. Now, one of my students, he did his part 1 ops and gynae, part 2 ops and gynae. He did the UK exams. And then when he did his posting, because he's already been with me here, and then when he did it in housemanship, he realized that he likes intensive care and the OT in the end. He said he likes that. So he switched. He sat for MEDEX and he applied for masters. That part 1, part 2 obstetric just stopped there. So you see, it's good to go through housemanship and you'll find that, oh, this is my niche. This is where I'm comfortable. This is what I want to do. So don't make many major decisions now. Unless you are really sure you want to become a physician, then you sit for MRCP part 1, part 2. Of all the disciplines, I think I find that to be the fastest. So if that's where your passion lies, I suppose you can do that. But look at this student of mine, he always did like what he was doing here. He said he did like it, but he wanted to do ops and gynae from before. So he thought he will just go ahead and do ops and gynae. But once he started practicing anesthesia, he said he wanted to change. He did, changed. So you can change anytime, it's what you want to do at the end of the day. You must be happy doing what you do. Don't be somewhere you are, you just do it for the sake of it and then you're not happy. To take it from someone who's been practicing for so long, yeah. Now you're starting out, it's different. But after a while, it gets to you. So it must be something you really enjoy.
Thank you so much. Thank you, Prof, for the very comprehensive answer for this question. So we move on to the third question. So, Prof, how do you think about anesthesia? Should it be integrated into medical school syllabus and curricula to better prepare students for this specialty?
I do. And
Mm-hmm.
it is in the medical curriculum. It is in the medical curriculum. It's just that, so I make the most of the 2 weeks that are given to me. See, so yeah, all IMU students get all those topics that I put there. They get all that in some way or the other, and hands-on skills on the simulation. If you're an IMU student, I think you can relate because that's what I believe. I believe that that's what you need to equip you for housemanship. Yeah, so I do believe that it should play a major role as well because we can contribute in these areas. We don't have to be like 1 month or 2 month posting. It can be, but it must be there and in an appropriate time. I feel that you need to be a bit more mature because it is a type of subspecialization, isn't it? Because we have feelers everywhere. We deal with medical patients, those in the radiology department. We give GA for MRI patients. So you need, because we've got feelers everywhere, you need to have medical knowledge. You need to have gone through all that to be able to be a good anesthetist, actually. So, so if looking at that, we can contribute in that way. So those are the components like, critical care of the critically ill, care of the unconscious. Half the time, patients in intensive care are unconscious. We knock them off with sedations. So, how do you manage patients like that? So, all that, and at least an introduction should be there in medical school. But I feel it should be when you're a bit more mature. So, final year is a good time, I feel. But being introduced to OT, pain, oxygen therapy, and all in year 3 is a good idea. So I feel that the new curriculum in IMU, because I've been given a role in the beginning itself, I'm able to plan out better for students.
All right, thank you, Prof, for the answer. So next, I believe, is the last question for the Q&A session.
Okay.
So there'll be Prof. Thiru. In the view of the current parallel pathway fiasco, what is your opinion or advice about pursuing the parallel pathway versus local master program for anesthesiology postgrad studies?
A very, very difficult question because of the current fiasco that you mentioned. Until they decide for sure what's going to happen, they come up with some policy or something that's going to protect you. I'd say just hold on a bit. Malaysian one you can apply, but many apply at the same time. So the parallel pathway was for students or participants who could not get into the main masters, who were good enough to go and finish off. It was a chance for the others because the main masters can only take a certain number, and they have some quota systems and all that. So the parallel pathway was for others, who wanted to take their time because it's a longer pathway. So I would say just hold your horses, just hang on a bit, let them in the next few months come up with something more constructive before you make a decision. The other option is to go sit for the Singapore Masters, like I did. I tried and tried and tried. I couldn't get a place. So I just sat for the Singapore Masters Part 1 and I cleared. Once I cleared, for some reason, I got a place in Malaysia as well. So what you can do is, the other option is sit for the Singapore Masters. And after you do your part 1 and your part 2, you can come back and work here. And you don't have to be working in Singapore. You can go there for your exams, but there are some criteria that are required. So with your Singapore masters, that is another pathway I'm just suggesting. You can actually try and see if you can go for FFA finals in UK. And Singapore, if you do your part one now, they expect you to have had exposure in all the postings, right? Like neuro, um, different disciplines. If you have already had exposure in neuroanesthesia, obstetric anesthesia, and so on, you and you give them the logbook saying, I've done this, and somebody signs you up, you can go for your part two already. So in a year or two, you can finish your master's already. And then you can try using that master's to apply for exemption in FFA, unless they have changed. But as far as I know, you can use the final master's for Singapore as to ask for exemption for part one, part in for FFA.
Thank you so much for the answer. And then
Okay.
I believe that I don't see any questions from the chat box. So I think that's it for our Q&A session. And
Okay.
next, we will move on to our next agenda. So next will be, we would like to present a token of appreciation to our esteemed guest speaker, Prof. Thiru. And we would like to also invite our president, Dr. Lim, to present a certificate of appreciation to our speaker. So Dr. Lim, yeah. So
I'm curious, how are we going to do this? Oh, okay. Yeah. You're going to send it to me, right?
So
Thank you.
Will get your souvenir soon.
No worries. Thank you.
Okay, let's have a photo together for this.
So you would like Prof and Dr. Lim to remain opening the cam and also remain you would like to take a screenshot of this.
Okay.
In the count of 1, 2, 3, show us your brightest smile. 1, 2, 3. All right. So thank you once again for Prof amazing sharing session. Next we will move on to okay. Next we'll be moving on to the photography session. So we'd like to kindly invite every single one of us to turn on your camera so that you can take a picture together for this wonderful moment as we are for this wonderful moment. In the count, okay, we'll wait for them you all to open the cam first. Kindly use our background virtual background that has prepared and sent to you all if possible. Together more.
I see familiar faces.
So I think okay, in the count of 1, 2, 3, we will be taking our group photo together. Okay.
Okay.
So please show us your brightest smile, yeah. Okay, in the count of 1, 2, 3, cheese.
There are 21 people here. Everybody is shy. They don't want to turn on their cameras.
1, 2, 3. 1, 2, 3. Okay, all right.
Okay. I just hope it has been helpful.
It's
More of
certainly
a
has been helpful.
motivator than anything.
So thank you everyone for your cooperation. So as our webinar comes to an end, we would like to once again show our utmost appreciation towards Prof. Thiru for a wonderful sharing session, and also like to thank all the participants for joining us today. We hope that you all found this webinar informative and inspiring. So last but not least, please scan the post-webinar feedback form to give us some of your constructive feedback to us. Your feedback is very valuable for us to improve for upcoming events. So the QR code is show up here, and I think I can also put in the link to inside the chat box. So I also send the link of this feedback form into the chat box. So I would highly appreciate if you all can fill up the feedback form so I can know what our weaknesses or what the things that we did not so well, then you can improve on for next time. All right, so
I think you've
let's
done a
not,
pretty good job.
Thank
A lot
you,
of
thank you so much.
Congratulations.
So last but can you move on to next slide? So last but not least, we are also offering free membership to every participant here today. So feel free to scan the QR codes on the screen to be part of us and get updated about our latest events and updates in the future.
Okay. Any other questions before we call it a day?
I don't see any from the chat. So I
Okay.
think that is all for now.
Okay.
Thank you so much.
Goodbye. And thank you. Yeah.
Thank you
Bye,
for
everyone.
thank you for coming
Thank
here
you for
today.
you.
Okay.
Thank you, Paul.
All the best, everybody. All the best, everyone. Not just IMU students, everyone. Bye-bye.
Bye bye. Thank you.
Prof.
Bye-bye.
Thank you so much, Prof.
Thank you, everyone.